Please give your attention to Dr. Edith Mitchell as she talks about colorectal cancer. Thank you.
Good morning. It is a pleasure to have everybody here and to focus on a disease process that in our community, in the African American community, there is a higher incidence of most cancers. I'm going to talk about colorectal cancer, but also disparities in terms of incidence. African Americans have a 20% higher incidence. That's a higher chance of developing colorectal cancer, and also a 40% higher death rate if an individual develops colon cancer. So I'm going to talk about some of the things that we can do as a group, as a community, to try and address these disparities so that a few years from now, we won't have the same statistics. My slides? So we're going to talk about colorectal cancer and some of the precision medicine that we are doing now and we have accomplished through the National Cancer Institute and through others, that we know that colorectal cancer is not one disease now. It is individual, and we will talk about some of those individuals. The learning objectives are here, and I won't enumerate them, but we'll go through and make sure that we reach all of these objectives. So the poet James Baldwin said, if you know, you always need to know where you came from. Know from whence you came, and if you know from whence you came, there is absolutely no limitations on where you can go. So for cancer, understand that over the last 2 to 3 decades, we have made tremendous strides. And what that means is that the cancer death rate in this country has decreased 25%. So there's been a drop in cancer death rates of 25%. Now, what that means is over 2 million people did not die of cancer. Isn't that wonderful? And it's not just the cancer doctors doing this, and I'm going to show you how it's so important for all individuals to come together, break the silos, work together. So, Dr. Wingfield mentioned that that there has been a decline, but that decline does not affect everybody. African Americans have not had the same declines. So again, 25% decline. And why? Well, a number of things. We've got better cancer prevention, tobacco being the greatest, as Dr. Wingfield mentioned, but we also have early detection. And colorectal cancer is one of those cancers where early detection has made a difference. And not only that, we have greater and better cancer treatment. So how about outcomes? African American women and men have higher death rates. I've mentioned with colorectal cancer, African Americans having a 40% higher chance of dying of colon cancer than others in this country. Early on in my training, I was told that African Americans come in with late-stage disease and there's nothing that can be done. But what our data now shows is that no matter what the stage, whether it's early or later stage disease, that African Americans have a higher chance of dying. So therefore, we have had to put together pathways that will help us address all stages of the disease. So one of the things that I like to talk about is Medicare. And you say, well, why Medicare and a colorectal cancer talk? And that's because now is the enrollment time for Medicare. And everybody, who has heard all the TV ads about sign up for this program for Medicare and sign up for that? Well, I want you to know we need to take heed of those and get the information. We did some research years ago on cancer payment of the cancer care and how it varies among races. First of all, note that for individuals aged 40 to 64, that private insurance, if you notice the white patients on your right, or actually, yes, your right, and the black patients on the left, note that private insurance covers cancer care costs at a much higher rate for white patients than for black patients, and Medicaid, of course, covering more. Well, you think that individuals age 65, that everybody should be the same, but it's not. Note that Medicare covers 68% of cancer care costs for whites and only 51% for African Americans. So therefore, the idea is it's very important for us to know our Medicare benefits, know how to approach them, form groups that we can help our relatives, our church members, and others choose the right plan, because colorectal cancer occurs more frequently in individuals over age 65. So most of these individuals will be eligible for Medicare. So this is the time of year, know your Medicare, speak with your churches, speak with your communities, and speak with your family members who are eligible. And then there are some of us who are also eligible for Medicare. So know your Medicare. Now, colorectal cancer. We do a lot of work for patients based on the markers. And if there's one thing I want you to take away today, it is know your colorectal cancer markers for any individuals who have colon cancer or who have family members. So we expect somewhere over 135,000 new cases of colorectal cancer to be diagnosed in this country this year, and some will be on the right side of the colon or the left side, and some will have localized disease. The idea is the earlier you find the cancer, the greater the likelihood of being cured, and I say cured of that cancer. And we can do that first by analyzing ourselves to see if we have a higher risk of developing colon cancer. And what are those risk factors? We've heard obesity several times today for multiple disease processes. Colon cancer is one of those diseases where obesity or being overweight is a higher risk. No activity, so inactivity being higher. Diets high in fat and processed meats. Smoking. Heavy alcohol use, and heavy alcohol use means more than 2 drinks per day for men and 1 drink for women. Being older, most colon cancers occur in individuals over 65, so as the aging process occurs, the risk increase. A personal history of colon cancer, or either having colon polyps, because most cancers develop from a polyp. A personal history of inflammatory bowel disease, having an inherited syndrome. That's really very important, and your racial background, racial and ethnic background, in that individuals, African Americans, have a 20% higher incidence rate, and having type 2 diabetes. All of these are risk factors, and it's especially important for us to know the family history. So the factors that allow us to select treatment are based on, 1, the tumor, whether it has spread or not, the patient, other medications that the patient might be on, or other disease processes. So we put this triangle together, and where it all fits means that there's personalized care for each patient. There's a lot of information now regarding whether the cancer occurs on the right side of the colon or the left side. Right side of the colon being at the area of the appendix, and the left side being at the rectum. So that is very important, in that right-sided colon cancers tend not to have as great a survival as those individuals with left-sided colon cancers. So it also allows us to choose treatment. The treatments that we use for left-sided colon cancers are totally different from those with right-sided colon cancers. So again, very important. Another factor that enters into the treatment is whether or not there is a substance in the blood that causes blood vessels to form in the cancer. And if there is a high incidence of blood vessels in the cancer, there are medications we can use to block the blood vessel formation and therefore starve the cancer. So that's one area of treatment. Another is whether or not there is an area on the cancer cell called the epidermal growth factor receptor, and that allows for faster growth, and we have medications to block that. And this is just an example of RAS. And the markers that I mentioned earlier, I will mention them again, but every patient and their caretakers and advocates should know those markers. So the first marker I want you to remember is called RAS, R-A-S, RAS. So know your RAS. The next one is BRAF, B-R-A-F. Know your BRAF, because that, again, allows for cancers to grow faster. Now, the important one for families is called MSI. So that's the next marker, MSI. Now, MSI is very important because, number one, these patients have a better prognosis. These cancers grow slower and don't progress. But it's important for families because there are family syndromes that occur where individuals may have had cancer of the uterus, cancer of the pancreas or breast, or kidney or bladder. So many times we think, well, nobody in my family has had colon cancer, but if they've had the other cancers, they are at risk. And there is a test that we can do not only on the patient with the cancer, but on other family members to find out if they are at risk of developing cancer. So talking to family members, testing all family members will be important. So know the MSI, and you want to know if the MSI is high or is it low or what we call stable. So testing other family members. So an example, if one family member has colon cancer or uterine cancer, we can test the patient to find out if they have the gene that causes MSI. If they do, we can test other family members, and the insurance covers the cost of that testing. So other family members can then get tested, even if they are not the usual age of 50. And regarding screening, screening very important. So talk to your doctor about screening. The recommendation is, since African Americans develop colon cancer at an earlier age, it's not the 50 anymore for African Americans. Get tested at age 45. Talk to your doctors about it and get the testing done, because while others develop colon cancer, median is 72, African Americans, that age is 65. So African Americans develop colon cancer at an early age. Get tested at age 45. And with the testing and with the known markers, we then develop treatment pathways. So understand, if you don't know your markers and you get a shotgun approach where everybody gets the same thing, you have put yourself at a disadvantage. Know your markers so your care can be specific and precise for you. And with all of the development over the years, note that when I was an intern and resident, and that was not too many years ago, the median survival of people with metastatic colorectal cancer was 6 months. Now it is above 3 years. And the reason is we've developed new treatments. People come in for clinical trials. So if anybody in your family develops colon cancer, or you know someone who you can talk to, ask them to at least check out the clinical trials, because all of these new treatments I mentioned, the ones blocking the blood vessels, the ones blocking epidermal growth factor receptor, these are newer drugs, and the only way that they were developed was by clinical trials. So after the clinical trials and you've been treated, what can the patient do? Well, there are some things. Physical activity, avoidance of fat diets, aspirin per day, but talk with your doctor about aspirin, and higher vitamin D levels. All of these decrease your risk of the cancer coming back after successful treatment. Physical activity, very important. And how much do we recommend? 150 minutes a week of moderate intensity exercise, walking, biking, and so forth, or 75 minutes of very intense training. 2 weekly resistance training. Choose a diet low in fat, high in fruits and vegetables, and limit red or processed meat. Just to mention about the Moonshot, where President Obama said we're going to get these cures out there earlier. Guess what? He put Joe in charge, and Vice President Biden has pulled together people, and we're working on things. One of those is disparities, ending disparities. So we all have to work together. So as I said, first thing to know, your markers, and MSI being the most important one for families, and then working with your community. So this is a representation of what I have put forth at our cancer center, that we want to increase the number of individuals going on clinical trials. We want to make sure that we're working with the community working with us, the churches and others, so that we're pulling together everybody, breaking the silos, so that we're all working to prevent colon cancer, to diagnose those with polyps or cancer at an earlier stage, so that the earlier the stage, better the cure rate. Putting it all together where families are working together, and we are passing on the information that colon cancer is not a death sentence in most cases. We can treat patients effectively, even if the cancer has spread to other organs of the body. So with that, this is Philadelphia at Night, and I thank you so much, and we'll answer questions later.